Hello and welcome. Today we'll be diving deep into a complex urinary system diseases, Staghorn calculi. These large, branching kidney stones can pose significant challenges, and understanding them is crucial for effective management. Let's explore what they are, how they form, and what can be done about them. So, what causes these formidable stones? Staghorn calculi are primarily associated with urinary tract infections caused by urea splitting bacteria. These bacteria, such as Pros Klebsiella and Pseudomonas, produce an enzyme called urease. Urease breaks down urea in urine, releasing ammonia. This process raises the pH of the urine, making it more alkaline. In this alkaline environment, magnesium, ammonium, and phosphate readily precipitate out of the urine, forming the building blocks of struvite stones. Less commonly, Staghorn calculi can also form from calcium phosphate or uric acid, often linked to underlying metabolic disorders or anatomical abnormalities. Now let's delve into the pathophysiology, or how these stones develop and affect the body. The elevated pH caused by urea splitting bacteria is the key player. This high pH favors the crystallization of struvite, leading to the formation of a nidus, or initial seed. As more minerals precipitate, the stone grows, often expanding to fill the renal collecting system, resembling the antlers of a stag, hence the name. This extensive growth can obstruct urine flow, leading to hydronephrosis, which is the swelling of the kidney due to urine backup. Prolonged obstruction and infection can cause irreversible kidney damage, including scarring, impaired function, and in severe cases, even kidney failure. Epidemiologically, Staghorn calculi are relatively uncommon, accounting for a smaller percentage of all kidney stones. However, they are more prevalent in women than in men, largely due to the higher incidence of urinary tract infections in women. Individuals with recurrent urinary tract infections, spinal cord injuries, and certain metabolic disorders, such as hyperparathyroidism, are also at increased risk. Geographic location and dietary factors may also play a role, but these are less well defined than the infectious and metabolic contributors. The signs and symptoms of Staghorn calculi can vary depending on the size, location, and degree of obstruction and infection. Many patients may be asymptomatic for a long time, especially if the stone grows slowly. However, common symptoms include flank pain, which can range from a dull ache to severe, colicky pain. Hematuria or blood in the urine is another frequent finding. Recurrent urinary tract infections, often with persistent or resistant organisms, are a strong indicator. Other possible symptoms include fever, chills, nausea, vomiting, and a general feeling of being unwell. Diagnosing Staghorn calculi typically involves a combination of imaging studies and laboratory tests. A non-contrast computed tomography, a CT scan, is the gold standard for identifying these stones, as it can readily visualize the size, shape, and location within the kidney. Kidney, ureter, and bladder X-ray UBA can be performed, but is not as sensitive to detect all stones. Urine analysis is crucial for identifying the presence of infection, elevated pH, and crystalline components. Blood tests may also be performed to assess kidney function and rule out any underlying metabolic disorders. While there aren't distinct types of Staghorn calculi in the way we categorize other diseases, it's important to differentiate based on their composition. Most Staghorn calculi are composed of struvite, resulting from the aforementioned urea splitting infections. However, they can also be composed of calcium phosphate, uric acid, or even, rarely, cystine. This compositional difference impacts treatment strategies, particularly regarding dissolution therapies and dietary recommendations. Treatment and management of Staghorn calculi require a multi-faceted approach. The primary goal is complete stone removal to prevent recurrent infections and preserve kidney function. Percutaneous nephrolithotomy, PCNL, is the most common surgical technique, involving the creation of a small incision in the back to directly access the kidney and break up the stone using various energy sources, such as ultrasound or laser. Sometimes, shock wave lithotripsy, which uses shock waves to fragment the stone, may be considered for smaller, less complex Staghorn calculi. Open surgery is reserved for complex cases where other techniques are not feasible. Following stone removal, long-term antibiotic therapy may be necessary to suppress residual infection and prevent recurrence. Furthermore, addressing any underlying metabolic disorders is crucial. Preventing Staghorn calculi primarily focuses on preventing and treating urinary tract infections, especially those caused by urea splitting bacteria. Prompt treatment of UTIs with appropriate antibiotics is essential. For individuals with recurrent UTIs, prophylactic antibiotics may be considered. Maintaining adequate hydration to dilute urine and prevent crystal formation is also important. Dietary modifications, such as reducing sodium and animal protein intake, may be helpful for certain individuals. Regular monitoring of urine pH and kidney function is recommended for those at high risk. The prognosis for patients with Staghorn calculi depends on the completeness of stone removal, the presence of underlying comorbidities, and the success in preventing recurrent infections. Complete stone removal significantly improves long-term kidney function and reduces the risk of complications. However, recurrence is common, even with optimal treatment. Recent research focuses on developing more effective antimicrobial therapies to target urea-splitting bacteria, as well as exploring novel approaches to prevent stone formation, such as the use of urease inhibitors. Furthermore, advances in minimally invasive surgical techniques continue to improve outcomes and reduce morbidity associated with Staghorn calculi management.